okay, you think it's quite a shock from such a very academic presentation to proctology. But I tell always the same story why I'm here. I went to London, I did 1,000 ERCPs in 2 years. I got back here and they were a little bit laughing about me because I could have done 50 or 60 years. So they sent me back to London, and I was with Michael Cam, Clive Bartram in London, and I learned something about proctoscopy. And luckily, I believe I have to, Professor Sewald said we should not show how good we are. I don't show that, but I introduced here the biofeedback. We did one of the first group, the botulinum in injection, and the university hospital laughed a little bit, or we had a discussion because they have done about 2 and we have done already a series of 100. And I thought it's really good. Nobody believed, but now it's final that botulinum is very important. Then we did a lot of different procedures for hemorrhoids. I believe surgeons are dangerous. They just went home, I hope. No, they're in the back. We will invite them back here. But I believe not in all cases you need surgery. We did Solestra. We did the first stem cell study, multi-center in Europe. And I learned about the 3D manometry and radiofrequency ablation. But however, in this field, there is a person who knows much, much more. And I'm very honored to present Professor Rao. He is not only the best in this field in the States, and he is a very, very good teacher. He has empathy, he's with the patient. I never forget the first patient had a stomach empty problem, and he always tells me, oh, you have to give this and this, try with that. I learned in 10 minutes more than I was sitting around here and looking through literature. But I say a secret to you, go to his YouTubes. They are funny, they are interesting, and you learn in a half an hour a lot of things. I test you if you know something. You know small intestinal bacterial overgrowth? It's something you know. Yes, that's all right. But do you know about FIGO, FIGO? You know nothing. I mean, I don't believe that you can treat patients if you don't know this. No, I'm a little bit, of course, over-exaggerating, but in this field, a lot goes on. The fee is for fungus, and that have to be treated completely different. We will perhaps hear a little bit, but this field is interesting because there are many, many, many patients, and we don't know what we are doing. So that's his present. I love to watch his YouTube. He has sense of humor, and this is for me great. And I had a chance to visit him. I was amazed. Now my colleagues told me I have to present the patient. That's our average patient. Incontinency, long-standing, everything performed, even neuromodulation twice, but still the patient is not happy. We recheck the patient. We don't know actually what the patient has. She has incontinency, she is weak, but we excluded all other causes for diarrhea because many incontinency patients have, in addition, a reason to be incontinent because they have diarrhea. So we performed this type of therapy. And now I want to know from Professor Rao, if we did it right, what can we do? Please. And here, just to show, this patient is running the Jungfrau Marathon up and down, and she wants to do it. And of course, with incontinency, she cannot do it. So our goal is to send her next year to the marathon. And I hope Professor Rao will help me now. Thank you very much for having this long trip to come to Zurich. Please.
Thank you, Andreas. I think what a beautiful introduction. I think I've had all kinds of introduction, but that tops it all. In fact, the photo clip, this was a presentation I just did a week ago. And I'm really shocked. So I never thought anybody would look at these presentations, but I'm really happy. At least one person does. So thank you, Andreas. And I really want to thank the rest of the organizers and my very good friend Joe and Gerhard and Bernard, everybody. Thank you so much for this kind invitation. It's wonderful to be here in Zurich. I had 2 glorious days and a lovely tour yesterday with the museum. So thanks for all of that. And you've given me a very easy topic, curing fecal incontinence. I mean, IBD, we will never cure. But here we go. We are almost there to cure this one, right? So I think let's roll. So these are some of my disclosures. Really, I'd like to thank the National Institutes of Health and the NIDDK for their gracious support for many years in this research. And also, I serve on the advisory board of a couple of companies that may have some conflicts with my presentation. So although my topic will primarily focus on management of fecal incontinence, I will touch a little bit on epidemiology, pathophysiology. We'll talk on some diagnostic approaches, and particularly some new ones that can be very important. And then we'll deal with some significant role for various treatment options. And I'm going to focus on a couple of really good ones, is neuromodulation therapy. So how common is this problem? And there are numerous surveys of this over many years. But this one survey, I think, literally caught my attention. This is probably the largest survey of community Americans. 71,000 people were surveyed using an app that Bill Che and Dr. Spiegel and others actually using it. And they found that the prevalence of fecal incontinence in somebody's lifetime in America is 14.4%, which is much more than IBD, diabetes, celiac disease, or IBS. So it is a common problem. And interestingly, in my clinic, I see 3-to-1 women compared to men, but either men are too shy, or they don't admit, or they tend to be too boisterous about it. But when you look at the prevalence in the community, it's almost equal, men and women. When you look at individuals over the age of 70, then it really becomes very highly prevalent, 17.5%. And if you look at nursing home residents, it's between 30 to 35%. So it incrementally goes up as we age and depending on comorbid issues and so on. But what the issue that drives people to come and seek attention is not just the fact that they're having stool leakage, but the impact it has on their day-to-day life. This is a study we did many years ago looking at quality of life. And significantly, when you look at a number of measures, patients with fecal incontinence have much lower quality of life. And when you delve more into their life, if you look at their psychological distress, it devastates them. I mean, you just need one accident in a store, and that's it. You'll never visit a store again. So this is a very life-changing, sad illness. We are otherwise physically well, but it can really cause significant distress. I'm going to share with you a story of my patient a little later on. And that really was such a strong message, and I think you will see something from that too. But I think it is useful as we look at these patients just to step back and think a little bit about the physiology and pathophysiology of the anorectum. And usually we think about it in the 3 Ps, I call it. One is the P for power, the passenger, and the passage. Now let's look at the passage. The rectum is a unique organ which is very different than the rest of the colon, as some of you will remember, because the colon has these 3 layers of Taenia coli with gaps in between. But when it comes to the rectum, it becomes uniformly covered into a single longitudinal muscle. And this longitudinal muscle extends caudally and meets imperceptibly with the pelvic floor muscles and forms that expansion, which is the external anal sphincter. And then the inner smooth muscle expands caudally and forms the internal anal sphincter. And the third barrier zone is the puborectalis. So these 3 muscles form the major barrier that holds us from leaking stool. We'll talk a little bit more about the anal sphincter and how important it is, and as described by somebody else, not me. But in addition to the barrier, there are the endovascular cushions, which sometimes become the hemorrhoids, which Andreas deals with very elegantly. And then there is the rectum itself. So the rectum is a highly compliant reservoir. I know Mark Fox has done some really wonderful work developing some tests for looking at compliance and so on. But if the rectum becomes more rigid, then your compliance fails, and you have a problem with accommodation. And this is a big issue in many of the IBD patients as well, and we studied that many years ago as part of my PhD with Nick Reed. But the other important component is the rectum is also a sensory organ. If the rectum becomes very sensitive, which you see in a number of patients, or is hypersensitive, in addition to the poor accommodation, then when even a small amount of stool comes into the rectum, their ability to hold becomes problematic, and then they leak stool. The third, the power part, is really the neurological innervation of the rectum. All my medical school and my early training days, we were only taught of one nerve, the pudendal nerve. Said everything, S2, 3, 4, this is the main nerve of innervation. But friends, I will tell you that I had to reread my anatomy in the last 5 to 10 years. That is not at all true. Pudendal nerve is only one tiny part of the neural innervation of the rectum. The rectal innervation is extremely complex. We have the pelvic sympathetics, we've got the parasympathetics, and we have ganglion, and the rectum gets enormous innervation from multiple other sources. So focusing on the pudendal nerve, we do a disservice to our patients, and we'll learn more a little bit later in my talk. So now about on the anal sphincter. Von Meyer actually made this a beautiful quote. Some of you may know this. They say man has succeeded where the animal fails because of the clever use of his hands, endoscopists particularly. Yet, when compared to the hands, the sphincter ani is far superior. Just imagine, if you place into your cupped hands a mixture of fluid, solid, and gas, and then through an opening at the bottom, try to let the gas escape, you will fail. Yet the sphincter can do it. The sphincter apparently can differentiate between solid, liquid, and gas. It apparently can tell whether its owner is alone or with someone, whether standing up or sitting down, whether its owner has his pants on or off. No other muscle of the body is such a protector of the dignity of man, yet so ready to come to his relief. What a beautiful way to describe the illustration. So when you look about fecal incontinence, it is a multifactorial problem. So I talked already about diarrhea and urgency. All of us, if you've had real urgent stool, we're almost at a threat of having fecal incontinence. And then there is the aging component. As we age, our nerves and muscles age, they degenerate, and that really sets a potential threat. And unfortunately, if you are a lady and you've had obstetric trauma, then there's significant muscle and nerve injury. And then the aging process gets accelerated. And that is why we tend to see women who unfortunately sustain an injury in their 20s or 30s present in their 50s and 40s, because that's when the aging process is catching up with them. And then spinal cord injury or neurological injury, talk about nerve, and then in the elderly, fecal impaction is another important source. But when we tried to look at these folks in a prospective study many years ago, we found that about 80% or so had a sphincter problem, about 50% had a neurological issue, and about another 40-45% had a rectal sensory problem, and an accommodation problem we saw in about 40%. But 80% of patients had more than one abnormality. In other words, if you have only sphincter disruption, and this is a question Andreas asked me many times, we see ultrasound defects, but yet patients are not incontinent. And that is true, because body has enormous ways of compensating it. But if you have more than one mechanism that's gone wrong, then I think we are in trouble. And if you've got more than two, then greater trouble. And that is why we need to be careful. When we think of treatments, we have to be thinking about combination therapy in a way. But we have to be thinking, what can we do to address the underlying pathophysiological mechanism? Whether it's 1, 2, 3, only then I think we can be more successful in getting to our goal of curing fecal incontinence. So when I see a patient with fecal incontinence, what do I do? First important is really try and establish a rapport and overcome social stigma. And even in my highly specialized clinic, I still see patients even today who will not come and tell me that they have fecal incontinence. They'll come and tell me, doctor, I've got diarrhea. So immediately, I know as a physician, as a gastro, your mind is thinking, okay, oh, maybe infection, maybe IBD, maybe IBS diarrhea, that kind of stuff. But the patient is hiding under the term diarrhea. They're unable to connect and express the embarrassment that they're facing, that this is actually stool leakage. So if you see a patient with diarrhea, I ask you one thing. There are only 2 or 3 things you're going to remember from my talk, but this is one thing I want you to remember. Please ask the very next question, is your diarrhea so overwhelming that you don't make it to the restroom? And the patient will say yes. Then you know you have a patient with fecal incontinence. So you'll find out when it happens, what are the precipitating events, how long they've had it, how severe it is, coexisting problems, particularly surgery and urinary incontinence, obstetric history, very important in a lady, forceps use, tears, presentation, repair, drugs, caffeine, and diet, and clinical subtyping. We'll talk in a minute. Then, we all say you should take a good history and so on. The question is, how accurate is our history? And this is very important. If you really think, many of you are good clinicians and you probably take good history, but not all of us are good clinicians. So we did a prospective study. We took about 100 patients, and we said, okay, we gave them a set of about 8 or 9 questions, as if the doctor will ask the same question. We have them record that. Then we had them keep a diary for the next 7 days. And we just compared about how good is their history by recall. I just want you to focus on the little orange segment at the bottom. The number of bowel movements, about 25% of the time, there was concordance between what they were remembering to what they were actually having. Stool consistency, 12.5%. Number of fecal incontinence episodes, only 21%. Amount of fecal incontinence, 11, and stool consistency, 17.8. So in other words, patients, when you have a chronic waxing and waning intermittent disease, you don't remember things correctly. Although you want to be honest with your doctor, you don't remember. So we as clinicians at this day and age should be doing better. How else can we improve our ability to get a better history? Try and get hold of these apps. There are 2 of these, one for constipation, one for the FI stool diary. They're now available on this app store. And you can have your patients keep it. Why? Because we now, every one of us, love to carry this thing into the restroom. You like it or you don't like it, you have it with you. So might as well use it, and use it for your own benefit. So I think you can, and it's very quickly, easily recordable, and it has some nice images. It asks you simple questions, the famous Bristol stool scale, are you straining, et cetera, et cetera. We've gone, and what is interesting, and this is the important part, I know some of you are in academic practice too, is this stool diary app has 2 components. It has a physician-patient component where they record all the symptoms, and then they can create a report which the physician can see or the patient can see. But there is also an investigator module component, which is very neat because the app actually gives you all the refined day-to-day information if you want to really collect this kind of investigator-use data. So how good it is? Well, we have done the validation of this now, and we did a couple of ways by which we validated. We compared within the same patient the electronic app versus a paper 2-week diary. This was a 4-week study. And also we looked at week 1 to week 2 data. Suffice to say that the interclass correlation is very good for a number of these measures we made. So I think it's a valid app, and the paper will come out soon. So what do you do next after you've taken a good history and maybe used an app to supplement your history? Well, you do a very thorough examination. This should include a neurological examination, especially in fecal incontinence. But the most important part is, of course, the rectal exam. You very good light, you need expose the perineum carefully. And now we all need a chaperone, please. I think Peter was talking about it. At least in America, it is mandatory. Even if I'm a male physician doing a male patient, almost by law, we need to have a chaperone. So things are changing in this world. Otherwise, you'll get a letter of complaint from the patient. So look for chemical dermatitis, look for rectal prolapse, perineal descent, hemorrhoids, and fistula and scars. But really more critical is really when you do the distal rectal examination, carefully advance your finger in the rectum. Before that, you do the anocutaneous reflex by using 4 Q-tips, and you'll get a brisk contraction of the anal sphincter. If you don't get it, then at the bedside, you should suspect there is a neurological problem. And then with your gloved index finger, you should assess the resting and the squeeze tone. The squeeze tone is important because there are 2 changes that happen. One, there is a circumferential tightening with the external anal sphincter that grips the whole finger in a normal individual. And then the second is the puborectalis, which is a U-shaped sling, will deflect the finger anteriorly. Many times in patients, when we're just doing this and we're not paying attention, we may think they may have a normal tone. That's because they're compensating with their puborectalis, whereas the external sphincter is very, very weak. So the next time you do it, you should be able to make that differentiation. And then, of course, important to really assess their defecation. Left hand on their belly, right index finger still inside the rectum. Have them push and bear down. You'll feel the belly muscles tighten. Your finger should move the perineal descent, and you should feel relaxation of the external anal sphincter, the puborectalis. If any 2 of these are not happening, then at the bedside, you suspect dyssynergic defecation. So there is, I don't talk about my papers, but this is one paper I really particularly tell all my residents, fellows, please read this one, rectal exam, published in the American Journal of Gastroenterology. Yes, it can and should be done in a busy practice. Now, this is an art that we all have to acquire as physicians, just like every other art, whether it's the knee jerk and so on and so forth. And you can see we did tandem rectal examinations after training one of my trainees, 10 on 10 exams with the help of the patient's permission and everything. And then I had them do this independent of me, and I did it as well. And then we compared the data. Junior trainee versus senior trainee. You can see that as a junior trainee, their ability to pick up dyssynergia was only 35% right. But when the person becomes a senior, almost 70% right. Fecal incontinence a little bit better because they're able to pick up loose sphincters, 59% as a junior trainee, but almost 92% as a senior trainee, third-year fellow. Normal exam, only 30% of the time they could say it was normal, correct. But by the time they become seniors, 100% of the time, they're able to say when it's normal or abnormal. So there is a learning curve, but it can be learned, and I'm sure we can all practice this. Now, clinically, I subdivide this into 3 types. Passive incontinence is the involuntary leakage of stool without any awareness. This is the classic example I gave you, somebody walking in a store and suddenly finds stool dripping down, and they had no warning, no idea what happened. Then the urge incontinence is where they know they have to go, but by the time they get to the restroom, it happens. And lastly, the fecal seepage, a more challenging group, where they may have a normal bowel movement, but sometime after that, there is a small amount of stool, 1 to 2 tablespoonfuls at most, may seep inadvertently, causing leakage. And then they only pick it up next time when they are checking their underwear. So this cord brown is a major problem. And so we really have to be doing something to help this. So who are these people? And this is a real direct quote from a patient of mine many years ago, and it really drove me, how much their lives are changed. She writes, "You feel so alone. You don't dare tell most people. They may avoid you or think you're sick. They may say, 'Go get help.' You have. No one understands unless they have suffered with this. Your life revolves around this. It changes who you are. The day begins with preparation to deal with it, and then it stays in your consciousness. The burden is exhausting. Alone, sometimes you just give in and let it run its course. You try to ignore it and go on with your own life. The shame seems unbearable. You try to forget that it happened, then it happens again, and it happens again. It can happen with no warning, without giving you a chance to even try to control it. You don't feel it or know it is there until you see it on your clothes. You're shocked, overwhelmed, and then numb. A sneeze or a cough can cause a loss of control. You use pads. You don't wear white or light-colored clothes anymore. Friends suggest alternatives: massage, acupuncture, naturotherapy, colonic cleansing for liver toxins, health food remedies, nutritional supplements. It all worked for someone. that they know. You change your diet, eliminate various foods. You feel better for a while, and then worse, you stop it all. Then it is another day, and you prepare to begin again. So this is a very good way to look at these people. This is how they actually live their lives. So what else can we do? Well, we have a number of useful tests that we can use. Why we need so many tests? As I mentioned at the beginning, it is not a one mechanism disorder. We have multiple dysfunctions, so we need many tests because one test is not going to answer all of these. So we use manometry to define the muscle and sensory function, and the sonography to really look at the morphology, compliance test to look at accommodation, and then we'll talk a little bit about the TAMS test and defecography. So manometry really provides pressure, sensory, and reflex activity of the anus and dynamics of defecation. We have a number of systems available. We've got flexible probes, and then we've got the rigid probe on the right side, which is a 360-degree probe. Each has their own pluses and minuses, and we sometimes use a combination to provide the most efficacy. Let me see if I can show you a normal. This is on a 3D manometry. This is in a healthy individual. Initially, you saw the green was the resting, and now we've asked the individual to squeeze, and you can see a nice uniform squeeze, a butterfly-shaped pattern on the right side, as if you have opened up the cylinder and cut it out. Now, we have a patient with fecal incontinence. You can see the muscle already, it's only green, and when they're trying to squeeze, it is not uniformly red, and in the middle, there's a big gap, particularly in the butterfly, and that is because there's a large anal sphincter defect. And we can pick up sphincter defects very nicely with this 3D configuration. So here is, on the ultrasound, normal ultrasound with intact internal and external anal sphincter muscle. The rest of it I've already shown. But in the lower panel, you see the incontinent patient where the internal sphincter looks a little bit more bulky, but essentially it's lost at the top. So it has, there's a large sphincter defect in both the muscles. And again, you can see the defect in manometry. So manometry will help you to confirm a clinical suspicion or diagnosis, provides new information, particularly rectal sensory and compliance information. In 84%, we found that it influenced the treatment, and even normal study can sometimes be very helpful. I'm so sorry, this slide didn't come out as I thought it would. I apologize. But I wanted to really put in a word for Mark Fox and the entire team in really trying to help standardize some of these techniques and technology over the last several years. We had used a protocol with the help of American and European motility societies, and then we've now moved on to the International Physiology Working Group that Mark helped to really put together, and then we followed up with a London classification. I don't have full time to go into that, but I just wanted to let you know that we are trying to get consensus and really move in a more standardized way. MR defecography is another useful test which adds another dimension. It provides that information such as rectal prolapse, external anal sphincter defect, and sometimes atrophy, which we can pick up much better. But let me introduce this new test, which is called TAMS. TAMS stands for Translumbosacral Anorectal Magnetic Stimulation Test. Relatively non-invasive test. And what we're doing here is we're trying to understand the complex neurological innervation of the pelvic floor, and we are picking up the nerves just as soon as they come off in the lumbar region and again in the sacral region. We apply magnetic coil to the lumbar plexus and separately to the sacral plexus. And then inside the rectum, we have a simple probe with 4 ring electrodes, measuring the rectal motor evoked potentials and the anal motor evoked potentials. This test takes about 15 minutes or 20 minutes individual, and we get comprehensive innervation from the point of origin to its innervation. And we get 8 motor evoked potentials. So if I'm stimulating on the right lumbar, as is shown in the picture, we get right lumborectal and right lumboanal motor evoked potentials. Then we go to the right sacral, we get the same like this, 2 more, and totally we get 8. And this has been a game changer for us. I don't know whether this video is going to work. Okay, here's a simple demonstration. A patient is lying down. On the back, we have marked the areas where we think it is, and I'm applying the magnetic coil. And there on the computer, you can see those are evoked responses. We get very good, very reproducible evoked responses. Here is a TAMS test in a healthy individual on the left-hand panel, and you can see the very prolonged time, almost 9.7 milliseconds it took in the patient with fecal incontinence. So how useful is TAMS? We did a large study, prospective study, published recently, and you can see that we find lumbar plexus and sacral plexus almost evenly distributed. But when you look at the site, the anal neurological injury is much more, almost 2 times more prevalent than rectal injury, particularly in fecal incontinence patients. So, with that as the background for evaluation and pathophysiology and testing, how do we go about treating these people? Well, clearly, if there's an underlying cause, IBD or something, it is appropriate that you treat them. You want to counsel your patient very clearly, make them understand what the problem is. And there are conservative or enhanced medical measures which will work in between 15 to 20% of cases. That is regulating their diet. If they have some issue that is contributing to diarrhea, such as lactose intolerance or fructose intolerance or too much caffeine and so on, you can modify that, and that can be helpful. Also providing them with antidiarrheals and anal hygiene and skin care. All of this is part and parcel of your medical enhanced management of this. With that, I said you'll get about 15 to 20% better, not 80%. Cochrane did an interesting review, like Cochrane always does, always comes with a negative result. So here is one of those. And then they concluded that focus of most therapy was diarrhea, not incontinence. And there's little evidence to guide clinicians. Larger, well-designed trials are required. End of my talk, you can all go home. But we can do a lot more for these people. So let's talk about biofeedback training. We've been doing this for almost 30 years. It works, but there are some challenges. We'll talk about that. But what are the goals of biofeedback? It is to strengthen a weakened anal sphincter muscle zone, both endurance training, which is important, as well as strength. Strength is we get them to squeeze and hold it for a few seconds. But the endurance is important, so we need to get them to hold for 30 seconds. Then if they have sensory dysfunction, whether it's hyper or hyposensitivity, we need to train them. And then coordination training is important. I'll demonstrate that with a graph in a minute. And then if you have dyssynergia, then you do another set of training. Here is a patient, a real patient with fecal incontinence. We asked this patient to squeeze. And if you look on the left-hand side, in P5, you see the scale 0 to 100. So the resting pressure is only about 15 millimeters mercury. And normally, for those of you who are not familiar, it's somewhere between about 60 millimeters mercury, normal resting pressure. And when we squeeze, we more than double. We go to 120 to 150, 175. And this person attempts to squeeze. It goes up to about 60, 70, only lasts for less than a second. It drops. We're asking them to hold, and you can see patient makes about 7 or 8 attempts and then completely fails after that. We're asking the patient to completely sustain this for 30 seconds, and the patient can barely squeeze. Same individual now, after 6 sessions of biofeedback training, the left 2 panels, you can now see that there is some increase in the resting pressure now to 30, but more important, the squeeze pressure has gone up, and the patient is able to sustain at about 100 millimeters mercury throughout the duration of squeeze without losing muscle function. Second time, again, we do it, and not much rise in intrarectal pressure. The next 2 panels, we actually distend a balloon in the rectum. So they feel as if there is some stool, and they have to respond to this quickly and sustain it, and you can see the patient learns very quickly and can reproduce this. This is a successful biofeedback training. Now, evidence, this is one of the best evidence from Dr. Whitehead's group, where they compared biofeedback against just the Kegel or the pelvic floor exercises, and they showed both in an intention to treat and per protocol analysis, there was significant improvement in fecal incontinence. But here are some challenges. Number one, biofeedback is not widely available. So what can we do? Perhaps we should be looking at home training equipment. We will have to train more faculty. We need more people engaged. And maybe we should use our physical therapy colleagues, who are often very enthusiastic, but neither are knowledgeable nor have the tools to rightly help these patients. Then there is concerns about standardization of biofeedback, and I think we should provide some guidelines. We are making some attempts in there. And this, I think, is very important. We really need to motivate a whole cadre of younger gastroenterologists and so on to really embrace this through multiple means. And last but not least, mechanism of action is always challenging, and we need to provide more evidence. Here is one, what I thought was a great solution. A company called Intone in America came up with this. So this is a combined therapy where you have a mechanical, that device in the middle, which says stimulation contacts. That is like a little bellows that you can distend in the rectum, and the patient can work against it. In addition, that is a little metal plate, so you can do electrical stimulation. So this is a combination of muscle exercises and electrical stimulation. And everything is done under voice guidance at home, so it's a 10 to 20-minute program. We were the first people and the only people now to test it, and we showed that the response rate, we compared home biofeedback with this device against our standard office biofeedback, and they were both very comparable. So we had equal response rate. Unfortunately, the device has just been withdrawn by the company. Nothing to do with FDA. They had financial issues. So this device, sadly, as of April of this year, it is no longer available. So I've been trying to help develop, and I've been getting a number of companies to deal with this. So far, I've not been very successful. But here is just a tiny prototype of this thing. I'm hoping that we're going to get a device by the end of the month. But what we are trying to, our aim is to develop a hybrid system that can be used at home or in office, which is Bluetooth, which is wireless. In other words, no hanging wires, which provides real-time and, more important, realistic system. This realistic thing is very important. Just think about it. All of us are scientists here. We know graphs, we know lines, we know pressures, we can understand. But imagine a poor, uneducated, who's only done 3rd, 4th grade, or maybe just graduated from elementary school, person with incontinence. And you're now telling them the lines goes up means pressure is going up, the lines coming down. They're confused. First of all, they're very embarrassed. They don't like all of this instrumentation being put inside them. And then you're telling them all these lines. I really feel sorry that we are trying to get them to do all of this. So this is the animation. And here, now the patient can realistically see. They all understand the rectum and the anal muscle. No one has a problem with that. They can see when the muscle is contracting and not, and they can have a realistic stool coming down, and they know they have to stop it. So if you can provide that kind of an input, I think this will be a game changer for our treatment for patients with biofeedback in the future for dyssynergia. Not there yet, but keep tuned, and importantly, invite me again. I'll tell you the story. So the dextranomer is what I think Andreas also already mentioned. You guys are already doing it. This is really an injection which forms like a little cuff just above the dentate line, and you inject it in 4 zones. And here is one of my patients with this. And this was the main study by Graf, which showed that 53% of patients responded compared to sham injection with saline. And there are a number of surgical treatments which only have been partially effective. I'm sorry, I know there are some surgeons in the audience, but I can tell you that. Here is a sphincteroplasty long-term data. Great in the initial months, and then as you follow them up, the curves actually fall off over time. Sacral nerve stimulation, again, is popular. I really think it works much better for urinary incontinence than fecal incontinence, but you do a temporary implantation followed by permanent implantation, and this is the best data from Wexner's group, showing that about 39–40% of patients will get significant improvement. And there are some plug-like devices which can be useful as a temporizing measure to let people live their activities of daily living. I have another case. I'm not going to go into this in great detail. Suffice to say that this lady tried a number of medical treatments and biofeedback, but still remained incontinent, a little bit like the case that Andreas just said. What else can we do for these patients? I shared with you the data that there is significant neuropathy in fecal incontinence. Almost 70–80% of patients with fecal incontinence have neuropathy. But yet, we are not able to really help them or treat this neuropathy. So we embarked on this treatment about 8 years ago now. We said, well, how can we give them outpatient neuromodulation therapy, not the implanted sacral nerve, which is highly specific to one nerve root on one side only, but we give a much more broader, because we've identified lumbar plexus, sacral plexus neuropathy. So we now use this magnetic coil, applied it to the same 4 sites, 2 lumbar sites and 2 sacral sites, and of course, what we didn't know was what frequency we got to stimulate. Here is a patient lying down and getting the treatment. And we tried our initial study. We compared 3 different frequencies. Now you may be wondering, why are we talking about neuromodulation? Because of this unique principle of neuroplasticity. Now, the nervous system has this unique ability to learn, adapt, and recover. A damaged nervous system can recover. So if you can harness this ability of the body to recover by driving that nervous system carefully through neurostimulation and repetitive neurostimulation, you can improve the connectivity and thereby improve the functionality of the gut. That is the basis for this. Here is our data, which we published a couple of years ago. And you can see there was significant improvement in fecal incontinence episodes in all 3 frequencies, but quite more significantly in the 1 Hertz group than in the 5 and the 15 Hertz group. We then looked at the responder rate. Here we defined the responder as having 50% or greater reduction in number of fecal incontinence episodes compared to baseline. And we were surprised that we had a 90% response rate in the 1 Hertz group, only 36 and 55% in the other groups. Our hypothesis was 15 Hertz was going to work because in the brain, that's what they do for transcranial magnetic stimulation, depression, and so on. So the brain works very different than the peripheral nervous system, and here we found that was really the lower frequency really was more effective. Here is an example in a patient in terms of nerve latency change. You can see 7.1 literally halved, and also the complex becomes much more bigger. We've gone on and studied them, and you can see really the red on the 1 Hertz column shows the dramatic improvement in everything. So TNT at 1 Hertz was clearly superior to 5 and 15 Hertz. It improved quality of life. It had a multidimensional mechanistic improvement, including anorectal sensory motor function. And neuromodulation therapy with low frequency appears to be safe and efficacious, at least for the proof of principle concept. What we are now engaged in is our next study, which we've now been enrolling for about 3 years, which is we're doing a sham-controlled study, longer duration, up to 1 year, and really that is what we really need to establish its efficacy, durability, and safety, and we will hopefully have the data. But I'd like to finish up by talking about something that again, Andreas just mentioned. This is really a kind of an innovative therapy. I mean, skeletal muscle-derived cell work has been going on in multiple fields. So this is a European study. I think Freudinger was the main author. Andreas and the team also participated. So they harvested pectoralis major muscle cells. They cultured it in tissue bath, and then they injected these cells into the anal sphincter. The study was interesting. Here is what you really need to see. There are a lot of people were screened and randomized, but there were 3 arms. The control arm was cell-free injection plus electrical stimulation. The low cell count was 5 into the 10 to the power of 6 plus electrical stimulation, and then the high cell count was 50 plus the same thing. So they had reasonably good randomization distribution. But unfortunately, the primary outcome measure, if you look at the responder rate at 6 months, no different. But then they subdivided them into 2 groups, fecal incontinence for less than 10 years, which was population 1, and fecal incontinence, once the TPP1 group with FI episodes more than 2 per week. If you really look at subpopulations, they were able to see some clear differences within the group. Again, if you look at the number of FI episodes, at 6 months was the primary outcome measure, 3.2 in the control, 4.3 and 4.8, not significant in the ITT analysis, but in a per protocol analysis, there is some differentiation based on some other criteria of subgrouping this. So I think there may be something to this, but question of who to give and maybe better selection of patients, again, we may be able to really help some of these patients with this. I mean, that was my take-home message. So where are we today with fecal incontinence? How good are we in getting the cure? Well, in terms of medications, mostly C's and D's. Biofeedback therapy, again, good level studies. It's A. Sacral nerve stimulation, good level studies, but there's only 1 sham control study. So we need more, better sham control studies. That's why the recommendation is B. For TENS, very popular, But now there are multiple studies. A large European study, again, came from Charlie Knowles, led it from England and across Europe, was not effective, so it's not recommended. Dextranomor is still 1A. Translumbal neuromodulation therapy, very early, 2B, and autologous cell transplant, very good study, the randomized control study, but recommendation, I would say, is B. I'd like to thank a large group of people who've been involved in my lab, whose work really is what I'm sharing. And so my main take-home points are the following. Fecal incontinence is a multifactorial disorder. It is important that you connect with your patients, establish a rapport, and take a good history, but supplement this, if possible, with more accurate history with stool diary, and a digital rectal examination is very, very important. We have a number of tools, manometry, ultrasound, imaging, deaf echography, TAMS test, which are all complementary because it is a multifactorial problem. It's only then you can have a better roadmap. Lifestyle measures, antidiarrheals will help 15%. Biofeedback still remains the mainstay. Perhaps home biofeedback therapy, if it can be done well, will be more effective. Dextranomor, selected cases surgery, TNT perhaps, and then autologous cell transplant. So in terms of curing it, this is my message. It amounts to a truism to say that progress in the practical arts of medicine in any of its branches, whether preventive or curative, only comes from the growth of accurate knowledge as it accumulates in the laboratories and studies of the various sciences. Thank you very much for your attention.